Good afternoon, everyone, and thank you for joining us for today's conversation on health and safety considerations for reopening safely our schools, particularly from K to 12, not only here in Philadelphia, but around the country. My name is David Rubin. I'm the director of PolicyLab at Children's Hospital of Philadelphia, which is a research center within CHOP's Research Institute. As the COVID epidemic began to unfold, we at PolicyLab knew that the working families that we care for so much here at CHOP and certainly work with regards to PolicyLab would be impacted significantly by the COVID epidemic, both related to the direct impacts of COVID for caregivers. I think we have 17,000 grandparents who care for kids here in the city of Philadelphia, probably 90,000 plus across the Commonwealth of Pennsylvania, but also the indirect impacts as people lost their jobs and their livelihoods related to the downturn caused by our response. And so knowing that and having done previous work around the impact of recession on families, we knew that working families would be both affected significantly, but also be the least likely to rebound quickly following the epidemic. And so as we began our COVID-19 response here at PolicyLab, it was very important to us that we help try to steward a conversation both through our research and through the people we work with, including this terrific panel we have today, on how to safely get people back to their lives, kids back to schools, and that's the nature of our conversation this morning. Today we're excited to be joined by a terrific panel of speakers to discuss this topic that's been on the mind of so many people. We've recently released our own guidance through PolicyLab that we did with our infection control team here at CHOP to really kind of bridge between. It's very consistent with the CDC recommendations that have been published in a lot of the guidances, but to kind of think more about implementation and deployment and the challenges about how do you take public health recommendations and really prepare for the nuances of opening different schools around the country. It's available at policylab.chop.edu. You guys could, everyone who's listening in today, feel free to go on our website and browse it. We've been providing guidance to school districts across the state and regionally, which prompted the interest in holding this event so we can have this wider conversation about from guidance to actual, what are we going to do? And so, a couple of reminders for those listening into today's presentation. All attendees' lines will be muted, and the video will be disabled throughout the event. We're looking forward to a really robust discussion. So if you'd like to submit a question, do so at any time. You can use the Q&A feature located on the right side of the platform. We're going to have our scientific director, Meredith Matone, who's going to help curate that with me so we can tee up some questions and after a brief set of introductory comments and some questions I have ready to go for these guys. So before we dive in, let me introduce this group that we've assembled here today. First up, we have Dr. Susan Coffin. Susan is a professor of pediatrics in the Division of Infectious Diseases at the University of she's a professor of pediatrics in the Division of Infectious Diseases at the University of Pennsylvania School of Medicine. She's an attending physician at CHOP. She's also the medical consultant in the Division of Disease Control at the Philadelphia Department of Health, where she's supporting the COVID-19 response for the city of Philadelphia, and we know her as everything infection control at CHOP. Next, we have Dr. William Hite, who is the superintendent of the School District of Philadelphia, the largest public school district in Pennsylvania. Dr. Hite's professional experience includes serving at every level: teacher, principal, administrator, and superintendent. Also with us joining Superintendent Hite is Matthew Stem, the Deputy Secretary of the Office of Elementary and Secondary Education in Pennsylvania's Department of Education. Prior to joining the department, Mr. Stem served directly in school systems for 22 years as a teacher, principal, and assistant superintendent. And lastly, because we knew school health and school nurses were going to be such an important component of whatever response we develop at the local level, we're excited to have Molly Tickner, the executive director of the Show Me School-Based Health Alliance of Missouri, an affiliate of the National School-Based Health Alliance established to improve the health of children and youth by advancing and advocating for school-based health care. And she'll bring up both a national lens and a focus on school-based health. I'm going to kick it off to Susan. And the format we're going to do here today, is to start with what we know about this virus and how that informs the type of things you've seen in the CDC guidance. And from that, I'm going to ask our other speakers to reflect from their own vantage points of how they interpret that information and how they think about using that information to open schools safely. So, Dr. Coffin, it's to you.
Great. Thanks so much, Dave. And I'm really happy to be here and participating in this conversation. Although I'm not an educator, I come from a big family of educators. I'm the only one around my dinner table who's not involved with education as a 100% endeavor. But also as a pediatrician, I don't think there's any issue more important to children and to children's recovery from this pandemic. I think that what I can do is share what we know about the virus, what we know about how it transmits, so we can design the safest possible ways to return children to as quickly as possible and as closely as possible to a more normal and more healthy existence at school and at home. So I thought I'd start just by sharing a few things that I take as givens, but I wanted to make sure that we were all on the same page. First, we are fortunate in many ways to be having this conversation about this virus, in that children are not the most impacted group by this virus. They're less likely to get infected. About 3% of total infections have occurred in people under 20 years of age. They're less likely, when infected, to get hospitalized. Adults are hospitalized at a rate of about 10 to 15%, but children get luckier. They're hospitalized at a rate around 5 or less percent. But I think where children are unlucky is just the huge magnitude of the indirect impacts of this infection on their lives. From disruption in the home, disruption in their social lives, disruption in their education and development. I can't think of one aspect of their life that has not been profoundly impacted. One of the important things I think that we can do is try and learn from the very small amount of data we do have coming from our own country as well as others about the impact school closures have had, and it's varied. We hear different stories coming from Europe. In some communities, such as Denmark, we're told that schools have been able to reopen and not experience a bump in disease. In other areas, we hear about schools reopening and having a surge in disease. One thing I think we do know, though, is that when we look at our own data, the data from the U.S., there are few communities that can say that school closure had a significant and sustained effect on reducing progression of disease in a local community. And I think that's an important thing for us to remember. This differentiates coronavirus from influenza virus. Influenza virus, we actually have good data to show that school-age children are big drivers of community infection and community outcomes. Thus far, we don't have those data for coronavirus. So the next thing that I thought I'd comment on briefly is what are the mechanisms of transmission? Because I think these are the things we do have the capacity to impact. We can interrupt the way the virus is moving from one person to another in an attempt to prevent it from entering the schools or to stop it from spreading in schools. And so some of the things that as we talk more about solutions, I'd like people to remember is this virus is primarily transmitted by respiratory droplets. It's not carried on air currents and traveling far and wide. The other main mode by which this virus is transmitted is through accidental self-inoculation. And by that I mean somebody accidentally is sitting at a desk where a prior occupant of the desk had a bad respiratory infection, happened to be coronavirus, and if you are unlucky enough to sit there next and then touch your face or your nose or mouth, you may self-inoculate. And so respiratory droplets and contact or transmission by hands are really the major ways that we have to think about viral transmission, and they lend themselves to prevention efforts. So in terms of what we can do, I think we can begin to extend the successes we've had in home settings to successes that we might have in school settings. We can use some of the principles of creating distance between people, between students, to create more protection. We can use principles of barriers, such as masks or other ways to interrupt passage of respiratory droplets from one person to another, to again interrupt transmission. And last, we can focus on the role of people's hands in a contaminated environment as things that we do have ways to reduce risks through. So with that, I'll pause, and I'm really eager to hear others' thoughts and comments.
Thanks, Dr. Coffin. Now, I'm going to go first to Dr. Height. There's a lot of guidance out there, including in the document that I referenced earlier in the CDC guidance. And as I've spent time with folks across the region and the state in the last couple months, there are issues of resources, there are issues of structure, there, in terms of how to do this. And we think a lot about our large urban school districts. And so I wanted to give you an opportunity. What do you see, and how are you planning for the reopening of schools as we think about September? Oop, I think you're on mute.
Thanks, David, and thanks for pulling it together and having this opportunity and providing us with the opportunity here at the school district. I also want to thank Dr. Coffin, because I think there have been a lot of assumptions around the transmission and the impact, particularly to young people, and I thought her information was very helpful. As we go to the first slide, if we could transition to the first slide. And I know we're talking about how, as a school district of Philadelphia, we're thinking about this. And before I introduce Dr. Barbara Block, who joined the Office of Health Services as our student health medical advisor, and she's co-leading our health services working group. She's from CHOP, and so we're gonna rely on her expertise. But while we think about the return to school and the safe return, and we think about all of the physical things that must be put into place, and we think about all of the social and emotional things we also need to put into place, I'm also very aware of the trauma many of our children are experiencing around all of the recent events, and making sure that we also have time, although maybe not with children directly, to ensure that we are helping them process things that they're seeing when they see reports of Black people whose lives seem to have little to no value. So I understand the fear that comes with that, and the fear that comes with seeing neighborhoods that they know and love destroyed. And so we also have to deal with now, on top of all of the implications of COVID, school closures, some pretty acute social and emotional trauma that has been a result of the events over the past several weeks and over the weekend. And so wanted to also put that out there, because that has to be at the forefront of how we're thinking about a return to some degree of normalcy. We're going to have to walk children through the social and emotional aspects of this, and then get to the structures and the schedules, what these things look like. But as I indicated before, pleased to formally introduce Dr. Barbara Block. As a pediatrician, she brings to us more than 15 years of experience and a proven track record of success caring for children in a practice here at the Children's Hospital. And so without a doubt, her experience is going to be invaluable to us as we think about what needs to be in place in terms of structures and processes and systems as we move to a reopening. We currently have, and I've talked about this multiple times, about 10 working groups, and they are each focused on critical areas of school reopening and ongoing operations. And those groups are considering several things. And if we could go to the next slide, please. So the group is really looking at 3 reopening scenarios, and all exist on a continuum. And like other districts across the country, we're preparing for a range of interventions. And what that means is that we're not looking for a one-size-that-fits-all approach, because our schools are very different. They serve different populations. They have different capacities and utilization percentages. And so we have to think about it in a flex way in terms of making sure that the structure or system is responsive to the community and and all of the things that has to happen at that school. But the three working groups are really looking at those 10 working groups are looking at three scenarios. Keep in mind as we think about returning in the fall, and we run an analysis on each of these. One is all students and staff remain in a remote or virtual environment. The other is a hybrid of staff and students who return to offices and schools on staggered schedules, differentiating them by, as an example, they could be differentiated by grades or by levels or by areas of the city, depending on the spaces that are available, and using personal protective equipment that provides some of the barriers that Dr. Coffin talked about. And recognize that there were individuals who, for a variety of reasons, both students and staff members, that will have to continue working remotely because of pre-existing conditions or vulnerabilities. And then the third scenario really is a full return of all staff and students while adhering to the public health guidelines. Now, which within all of those scenarios, as I indicated before, there are multiple models that could be implemented, and we have to evaluate each of those. And we have to make sure we are considering the constraints of parents and families that have to return to work, employees and other stakeholder groups, and all of the associated risk. And the goal of making sure that we're able to provide the best educational experience to all of our students. And so I want to just, if we could go to the next slide, talk a little bit about as we consider scenarios, we are faced with a set of challenges, and we already know those challenges that consist of many of our facilities. They present a challenge in and of themselves because of the average age. Our schools are 78 years old on average. And they contain compact classrooms, and in many cases with limited ventilation. And so these are important considerations given the limited data on school-based transmission and the possible risk to both students and family members. And for this reason, it is critical to have strong safety plans in place, as well as flexibility so that we can utilize or begin to implement a scenario based on the environments that exist within the schools. Another consideration for any large urban district, not just here in the Commonwealth, but around the country, and smaller ones, is meeting the needs of all students, including those who are undoubtedly experiencing increased levels of trauma, both from the extended closures, but they're unique groups that have had services removed because we could not do those services in a face-to-face type of approach. So we need to continue services that our students rely on, including the things like meal distribution, medication, dispensing, school-based therapies, behavioral health, and counseling services. And then given the diversity of all of our students and communities, it is also critical that we have regular and accessible communication to families about our protocols, our schedules, and available supports. And one thing that I didn't add is inside of all of these considerations are also how do children get to and from school. We have 70,000 young people in the city of Philadelphia who take SEPTA, mass transit, every day. And so we also have to work through all of those types of processes to ensure that not only are we thinking about schools and the distancing that should be in place in schools, but children coming to and from schools as well. And I'll stop there and save the rest for any responses to questions that I'm sure I will get.
Thank you, Dr. Haidt. That was terrific. And as I sort of continue to work as I become knowledgeable of the district here in Philadelphia and now work with Matt at the state a bit to understand the rest of the state, every district is facing its own sort of questions of what are the capacity to expand sort of environments to allow for smaller classes? How do they implement the distancing recommendations? Everyone has the unique set of challenges, and so I've asked Matt to come here today, talk a little bit about just the ways in which districts are very different over the Commonwealth of Pennsylvania, which also has the largest rural population, I believe, in the United States. And so, what do you think, Matt? I mean, how do you react to this guidance around when you think about just how different the school districts are throughout the state? You're also on mute. There you go.
There we go. Absolutely. No, thank you, Dr. Rubin, those at the PolicyLab, and everyone that's involved in today's session for your leadership and collaboration on such an important public health and safety issue. It's a pleasure to be here on behalf of the Department of Education. And you're right. As we think about flexibility in scenario planning, I think it is helpful to look at what the unique context is in Pennsylvania that informs our policy making to ensure that we're creating the conditions for each community to respond effectively. If we could start with the first slide, if we have that. So here's some context that I think is helpful background around the Commonwealth. And Pennsylvania is different than many states in a lot of ways. So our K-12 education system serves more than 1.7 million students. But when you look at the diversity among where those students attend school, we have 500 school districts ranging in size from as small as 200 students to more than 140,000 students. And, by example, many states have county-wide school districts and school systems, but with 500 districts that we have a lot of unique scenarios. And so you look at not only size, but also the context in which students are learning. We have 164 brick and mortar charter schools and 15 cyber charter schools that are responsible for educating over 135,000 students. And finally, we have 16 comprehensive career and technical centers, 68 occupational career and tech centers, and then 135 high schools offering CTE programs for over 67,000 students. So if we can go to the next slide, just to unpack a little bit more, again, some of the diversity by enrollment, I think some of these trends are even more striking. And as Dr. Rubin spoke about sort of the urban and rural dichotomy that we have in Pennsylvania, you look on this graph and you'll see that 60% of the students in the Commonwealth are served, 60% districts in the Commonwealth, serve fewer than 2,500 students. And we only have in the Commonwealth 17 school districts that serve more than 10,000 students. With Dr. Haidt here on the call, we know that Philadelphia School District serves, somewhere between 135,000 and upward students. And that even puts Philadelphia in a very unique position because the next largest school district is Pittsburgh with roughly 25,000 students. And so how do we create policy and flexibility that accounts for all the unique issues that each of our communities face? So if we go to the next slide, I just want to bucket these in a few areas that underscore the importance of the local flexibility and scenario planning. So first, there's the community context and then monitoring of trends in those communities. So as we just mentioned, with those diversity of schools comes diversity of certain issues. Dr. Haidt mentioned transportation. That's an excellent example. You have a school district like Philadelphia where transportation for tens of thousands of students is through public transportation, in that case SEPTA. And then we also have school districts where, for example, in one of our northwestern counties, there are only 2 schools in the entire county. So the children that are on buses, it's for some an hour or more each way to school. So how do we at the state level push out guidance and frameworks that allow enough flexibility for a district like Philadelphia versus a district like one of our rural counties to do risk mitigation in those unique settings? The The other area that comes into play within the context of different communities is the age of buildings. We have some buildings that have very modernized facilities with large spaces, and we have other districts that, particularly in our urban centers, that have very old buildings with not only limited ventilation, but also smaller class sizes and limited ability of the facilities to allow for certain flexible social distancing practices. So again, the guidance that we put out at a state level has to attend to those types of issues. And then a third area under the community context and monitoring is around flexibility for districts and communities that are going to find themselves with rising and diminishing numbers of cases that, districts that are in let's say a green county right now could move to yellow, could move to red, or the other way around. And so there has to be flexibility in planning to account for the different numbers of cases that exist. And also, by the way, even schools within a county where there are a very low number of cases may have a school or a district where there is an outbreak. And so those plans have to be flexible enough to accommodate for the dynamic and changing conditions. The second area to focus on when it comes to flexibility has to do with the age of our students. Many of our schools serve very young students. We have primary centers throughout the Commonwealth that serve, K-2 and sometimes even 3- and 4-year-olds in their programs. And so we know that whatever frameworks are in place and guidance at a state level have to account for the differences between younger students and older. So, for example, the state would likely recommend, or we would recommend when it comes to things like face coverings, that those are best suited for older students, and even then, only as appropriate. So considering age of students is important. Third, we need to think about the services that students need as part of their education. And different students receiving services require different levels and types of services in school. And so, for example, you have some students that receive occupational and physical therapy. So plans have to allow for the flexibility of how to provide those services in one of the various scenarios of remote or hybrid type learning. But then also things that folks often don't think about. We have programs like career and tech programs where, to be honest, students that are in a welding or a cosmetology program of study have different needs of access to materials and resources than a student that's in another program. And so all of this impacts the manner in which schools schedule and use their learning spaces. And then finally, to close out with this thought, we really have to keep equity and access at the forefront of everything that we do as a Commonwealth. And we have vulnerable populations that are at increased risk, those that were already at risk before COVID and are now at increased risk. So, for example, we have economically disadvantaged populations whose families are disproportionately either in service industry jobs, which has been requiring them to work, and in some cases work in long hours with some degree of exposure. We have agricultural workers. We have families that don't have sick leave and are forced to make difficult decisions that then impact their students and then certainly impact the manner in which they're being served. And finally, particularly among our economically disadvantaged population, we have the issue of access to technology and limited access to technology. And then the last two groups, really just to highlight, we have our homeless populations. When I was a school principal, we served 3 shelters. Our students attended 3 shelters, and there's an increased exposure at shelters. So how do we account for that? And populations like English language learners as well that require communications plans that are differentiated. So, in short, we know that at a state level, our policies and frameworks have to allow the flexibility for local districts to plan with their partners and stakeholders in ways that account for their local needs.
Thank you, Matt. That was terrific. And before we get to the Q&A, I'm really excited to have Molly here. Molly, the folks you work with, the school nurses that are out there every day, where, they're often, in many districts, particularly our larger districts, there's not enough nurses and not enough staff, and you're working in very different environments. And so you're sort of operating, your teams are operating in the intersection between the public health guidance and the actual daily life of a school. And so what are you seeing out there, and talk a little bit about Missouri's plan for us and how you think about school nurses in general and school health.
Thank you so much, Dr. Rubin and everybody. It was wonderful to follow up and share a little bit about what Missouri is doing, learning from what you guys are doing across the country. So the Show Me School-Based Health Alliance really is focused on building relationships between healthcare providers and schools to bring the valuable and much needed holistic healthcare to our schools. But part of our biggest cohort is school nurses. They're actually one of our biggest stakeholders in bringing school-based health service to the school. So we're really excited to be able to present the work that we're doing around the state to help support our schools, plus our school-based health providers. You can go to the next slide, please. One of the things that we've done, our governor in the state of Missouri has tasked us as part of the Alliance and the Missouri School Board Association, their Committee for Education Safety, to create a reentry guide. So we started this process back in probably early, right when COVID hit in Missouri in March. And we had some really great minds coming together, including some of our education departments, as well as our Department of Health and Social Services. And then the Alliance was speaking primarily to the health and social emotional health when we look at school reentry. So it was wonderful to have the support from the state and our governor to be able to convene this task force and create this document. It's now been shared with several other states as kind of a guiding tool, but much like my colleagues have said from Philadelphia and you all in Pennsylvania, it needed flexibility. And so we know that this document, although it's 98 pages long, it has been changing daily because we know that our schools and the climate of COVID has changed. But what we really tried to focus on was just basic guidelines, because our schools, much like Pennsylvania, are extremely diverse. We have districts that have less than 25 students. We have districts that aren't as large as Philadelphia, but still have a large urban area. And then we have some other districts that are in charter schools as well, particularly in St. Louis and the Kansas City area, who have very, very smaller communities. So we wanted to be very clear that this is not a one-size-fits-all document, that we just really wanted to provide guidance to. These are all the things to consider. We know that flexibility is definitely key as we go into the fall school year, and most of our schools are looking at similar models that you are. So in looking at that, we broke it down into 8 categories, and what you see in front of you are the 8 categories that we had experts in the field from the Missouri School Board Association, as well as ourselves and some other state agencies, to help looking at what are the things we need to consider. And then we broke those down even further to create somewhat of a checklist, as well as templates from other districts and other organizations to help our schools really develop plans around each of these categories. I will say, just speaking to this slide, that the number one important portion that we felt was at the top of the list, especially now before school starts, is developing that communication plan. How are you as a district communicating with your staff, communicating with your families, communicating with your stakeholders and your partners? So having those conversations really early and often to be able to communicate out. And as things change, so maybe you thought you were going to start out doing a hybrid model, but then you had to change it up and look at something different. And so how are you communicating that out in terms of what operations are going to look like? So just some things to consider. That's the document's guiding format that we utilized. However, we really focused on creating the actions around the health and how the nurses are utilized, as well as our social emotional health. Go to the next slide, please. So school-based health programs, and this also includes the school nurses. So when you speak to the value of the school nurse, most of our school-based health providers work directly with the school nurse. Our school nurses in Missouri do not have capacity to be that primary health provider. They are triaging, they have multiple things going on. And so what we found was, how can school-based health programs work collaboratively with our school nurses, work collaboratively with the administration and the counselors to help with some of the issues around the COVID-19 and school return, as well as closing the gap now. So how can they help with some of the things? School nurses, at least in the state of Missouri, and I'm not exactly sure how it is in Pennsylvania and other states, don't have the ability to do diagnostic testing. So the role of a school-based health program to help with providing some COVID-19 testing, if they have been approved by the government to be able to do so as an entity, is extremely valuable. We have some school-based health providers that are working with their school nurses to already identify some of the high-risk students. That's the other value of a school nurse, is they have to track all of the students that are basically high risk for, asthma or obesity, as well as diabetes. And so they have that list of those students that they can share with the providers and share with the administration to say, hey, we need to start checking on these students to see how they're doing, what's going on with their families, how can we outreach now so that when school does go back in session, we can make sure that we're meeting their medical and mental health needs. But these are just some things that a school-based health program at least has been doing or can help support in our schools, and how we know that a lot of our school districts are very limited on protective equipment, as well as thermometers and different things to help with the screening process of COVID. And so our school-based health programs have been able to access some level of funding to have some of those medical supplies available to help the school nurse with some of those issues, and as well as the other staff in the school. The other thing I think is extremely important that I think one of my colleagues alluded to was educating staff before school gets back in session. So what kind of professional development are we providing staff at all levels and our families in terms of how we're handling this? What is it going to look like? What are some signs and symptoms? Because we know that our families and our students and our staff are going to come with high anxiety to this situation when school comes back. So the more we can do to educate them ahead of time, the better. And our school-based health providers and our nurses can play that role in educating to kind of debunk some of those myths, hopefully bring some of the anxiety down about returning to school. Next slide, please. So just some considerations in terms of, we truly believe this is just the premise of the Show Me School-Based Health Alliance, is partnerships, partnerships, partnerships. So how much are our schools collaborating with their partners? Are they using the school nurse and their contacts to reach out to their, like their hospitals and their local health departments and their providers, and having them sit at the table to help kind of problem solve, brainstorm some of the issues and some of the barriers that are going to come. So much like what Dr. Haidt spoke to, having periodic meetings throughout the summer, we've heard a lot of our school districts creating task forces. They're meeting regularly and to truly identify their roles and their responsibilities. We know that a school nurse is going to have specific roles and responsibilities, but are we communicating that out to our staff? Are we communicating that out to the partners? This is what we're going to do. This is what we are going to do. So it's very, very clear, because there's going to be a lot of confusion when fall and school starts. And so to hopefully eliminate some of those confusions before they even start. And also looking at the reentry guide that Missouri created, we pushed that out to all the schools, both public, private, and charter in Missouri. And so when we started to have conversations with our local health providers, both hospital and private and public health providers, we want to make sure that those reentry plans are making sense and they coincide and they collaborate. So my reentry plan as a provider might look differently than my reentry plan as a school official. So making sure that we're communicating and that those decisions are being made jointly. Looking at those health priorities that I spoke to earlier, as well as, providing education. We know that our staff are going to come with a lot of trauma. I know Dr. Haidt spoke to our families are going to come with a lot of trauma, but our staff might as well. So what are we doing to provide that support to help support our staff with some of the traumas that they've experienced over the summer and with some of the things going on in our environment now? And obviously collaborating with your school social workers if you have them, case managers, to address some of those social determinants. So if your school nurse is able to make those referrals out, do they know where to make them? Do they have that warm handoff so that when they do have to make a referral for maybe housing insecurity or follow-up mental health services or whatever that looks like, they have the ability to show the family and the student where to go. Next slide, please. Just a quick wrap up. So these are our resources. The document is available on our moschoolhealth.org website. It's free to share. Like I said, multiple states have been used as a platform to create their own. I will say that we've really collaborated as an alliance and as the Missouri School Board Association with our Department of Elementary and Secondary Education, and they are extremely understanding that when school does come back in session, yes, academics is our job, but our focus is going to be on the health and safety and well-being of our staff and our students. So we need to work on building back the trust. We need to create that environment of not just physical safety, but emotional safety. So they've already put the message out to all the districts in the state to say, hey, we need to focus on this because we know that kids can't learn unless they feel emotionally safe and physically safe. So that's really the focus of our true collaboration in the state.
Thanks, Molly. So much to think about. I mean, and only a short time to go. As I was listening to all your comments, I mean, first of all, I just want to, for Molly and for the school-based health programs, lots of questions out there, and I think it's more of a statement, which is to acknowledge we need more support in our schools this year, and whether that's, school nurses are using nursing some assistance, that might be, students who are, younger kids who, younger adults to assist school nursing programs and school health programs with the amount of activity that's going to be on with immunizations, with other health issues and other outbreaks, even, with regards to chronic health conditions like asthma or a lice outbreak within a school, those types of things that there's going to be a need, some focus need on increased capacity. So I thank you for your comments. Now, as we start to kick it off, there's so many questions out there. I'm going to try to develop a game plan for the next 15, 20 minutes. I mean, number one is there are a lot of people asking, why are we doing all this? The kids, they're not getting sick. Why aren't we building herd immunity? And for those people, we recognize that this is about, largely, even though there's some rare, really serious complications in kids, this is about protecting their caregivers and protecting teachers and the staff in these schools. And so then when we go into that, like Dr. Coffin said, we talk about respiratory transmission, we talk about fomite transmission. We'll assume for fomite, even though there's definitely debates about hygiene and disinfection, we're going to put that on the side because everyone's really interested in these distancing and masking recommendations. And the degree, are there bright lines here in terms of what we're going to do? Are we really going to mask kids? Who wants to kick off that discussion? And what are the masks? What are the type of PPE we should be using for our teachers and our staff?
I'll jump in as the ID doc on the panel to start, but I really do want to hear from my education colleagues to set me straight about what this looks like in action. I think that at times in our community where there's significant levels of viral transmission, there may be a role for in-school masking, recognizing that it comes with a lot of problems, and it has problems with basic communication, with development and social interactions. So it's not an ideal. And that's where you begin to think about what are my trade-offs? If I don't want a mask, can I maximize distance? And for me, when I begin to think about how we can use our tools, it's a strategy of layering tools and prevention strategies on top of each other, informed by what is the current risk of disease. And luckily, the risk of disease will not be static throughout our season. We'll definitely experience some lows, and we'll probably experience some higher levels than we have at this very moment, at least in Philadelphia. And I really like the comments of all of the panelists about having plans that are dynamic and flexible and anticipating you're not going to be doing the same thing in the same way across the entire school year.
Other thoughts before I tee up the next question? How do you guys think about masking? I mean, from the perspective of deploying them in schools.
Naturally, I'm thinking about it differently since reading the report, right? So because going into the report, we were making the assumption that then if individuals were going to be out publicly, they needed to be in mask, and then therefore children in schools should be in mask. But thinking differently about who is masked or who should be wearing a mask in schools, and with respect to adults who are in the building, perhaps, and even in the report it talked about the types of masks that individuals could wear as they're dealing with certain populations. And so focused a lot more now on maintaining records, ensuring that there's appropriate distancing, and the sanitation and hygiene around after every child leaves a class, taking it and making sure we have those systems in place that things are wiped down before another child comes in. And so those are the ways we're thinking about this, as opposed to just everyone in mask. And I will tell you that has changed in the last 30 days, because we were originally thinking we had to get masks for children in schools, and schools were already trying to acquire masks with logos on it, and then we were all talking about how we're going to enforce it. What if children refuse? What about young children? I mean, so it was just so complicated. So I'm glad to hear Dr. Coffin talk about that.
This is Meredith. I just wanted to jump in. Dr. Coffin, can you respond? There's been a number of questions, I think appropriately so, about face masks and their efficacy. We know that face masks, the advantage is that it allows a student to see a teacher's full face, which is very important. And so can you jump in with some comments on your thoughts on the efficacy of face masks versus shields?
Sure. So there are a variety of different ways. Well, first, I think the question is what's the function of a face mask? And so the function of a face mask is to prevent the person that's across the table from you from getting any of your respiratory droplets. The idea is that you don't want to send them out, because you might harbor virus and inadvertently pass it to the next person. So in that way, it's the mask wearer who is conferring benefit to the non-mask wearer. In terms of thinking about alternatives to masking, face shields have been used successfully to reduce risk, but they don't reduce risk as much as a face mask does. So in all of public health, there's a balance, right? So we could achieve a lot of good by having full visibility of one's face for all of us, but it might come at a slight cost of not as effective protection against transmission. And then the last thing I'd say is while I love the idea of children returning to school without any consideration of masking, I'd be not fully honest in saying I see that we are going to need masks in schools at some times, at the very least. And I wish it were otherwise, but I do think we're going to need something in that family to be able to be used at some point during this upcoming school year.
Well, another area that, feel free to comment, Molly or Matt, if you want as well, but I think just to keep things moving along, I mean, you have the masking challenges, and then there's a lot of this stuff about about distancing, the 6 feet between desks. And I think, as I've listened to folks over the last, are there bright lines there? I mean, we've talked about occupancy as a better estimate, in terms of density of folks within a room, rather than trying to just overmanage distance within the setting. Distance from teacher to students may be more important than distance between the students. Talk a little bit about that nuance and what's really possible. Certainly, I think about that, Dr. Haidt, for your district. Is that even possible, right?
Yeah. So I'll take the first response to this and just say, this is I think this is the common theme, right? Is the trade-offs in where we establish some of the lines on these. And I think it's why at a state level, we have to, again, allow as much flexibility as possible while doing the intellectually honest and important work of putting out guidance. And so the CDC has been pretty straightforward about the best practice of separating individuals at least 6 feet in as much as possible. We recognize the challenge that creates for districts, again, particularly a district like Philadelphia, and what the implications of that are. And I think that's why looking at risk in a district and looking at transmission in cases has to inform whether or not, to what extent districts, how they handle that social distancing within occupancy in the spaces that they're using for learning, as well as other activities. I mean, we would make a case that districts should be using classrooms for meals as opposed to cafeterias, if at all possible, those sorts of things. But everything is going to be a balance between the trade-offs on these, and we do recognize that.
Other follow-ups?
So, and David, you asked, like, is it possible? I mean, and I would say it varies. I mean, it varies by school, by the design of the school, by the age of the school, by the populations of children that are served. But in many areas, at least in the school district of Philadelphia, that which has been described or recommended is impossible. I mean, and so if you have small classrooms that only have 30 children in them and a teacher's desk, and you have no room to moving children 6 feet apart can't be done taking that same approach. And so we'd have to think about multiple schedules or multiple days or utilizing spaces very differently. And, we start one way and have to, as Dr. Coffin described, we may have to start using one system and then move to a different system as things transpire. But by the same token, we have to take into account that for many of our our schools serving elementary children, that's impossible. I have elementary schools with 2,000 children in them. I have high schools with 3,400, and you cannot separate those young people 6 feet apart. It's just impossible.
Now, Molly, I'm going to tee you up in just a second because we're coming to surveillance and sick policies and those types of things. So you just hold for a moment. I think I kind of have felt that, Dr. Hite, as I've which is to say there are trade-offs, and we have to recognize that, in some ways the mixing of students is unavoidable, right? And maybe we should be focusing more on how we protect the teachers or protect from being exposed themselves, but also from exposing the students, because they may likely be high transmitters. Now, another question you sort of touched on hybrid schedules, and I see a lot of questions out there. We know that there's a delicate balance for most of our families where schools are a part of how people work. If their kids are not in school, there's two elements here. If their kids are not in school, then they can't work, right? But in addition, we also have special needs students who really, the data is pretty convincing that online education for most students, particularly those who receive special services, does not work as well as in-person learning. And so, is hybrid scheduling realistic here? I mean, how's that really going to work?
Yeah, I mean, and it's the things that are being considered, and the things that are being considered around the country, not just here in Philadelphia, are in some cases a morning, afternoon type of approach where all children come to school every day, but the time that they're in school may be reduced to a period of the day as opposed to a different period. That way, you can get twice as many children into the same areas. But even in some of the schools that I just described, even that would be difficult to do. Another approach could be looking the levels of schools differently. So high school students may stay in a very different or virtual type of environment while we gain the access of those schools for elementary school students, and so or those very vulnerable populations. And so there are multiple ways you can think about it. And some individuals are saying that certain children will come on Monday, Tuesday, Wednesday of one week, and then Thursdays Tuesdays and Thursdays of another week, and it flips, that will be a nightmare for families. And so and people would be every week trying to understand, like, is this the week? Is this the 3-day week? Is this the 2-day week? What do I do when I have to go to work? And so as we think about that with older children, it produced different set of considerations than as we think about it in the elementary schools, where when those children are home, generally parents or someone will need to be at home.
Yeah, well, great. I am as we continue into this conversation, I will say it's one of the great things about being a moderator is you can just say, we're going to extend over a few minutes because there's just too many questions coming in, and I have command of the room, right? So we're just going to keep them coming. Mary, do you have any follow-up questions to masking and distancing that you want to ask?
If we can get Susan with a very abbreviated answer on temperature checks and daily temperature checks. And then what I'd like to do is, again, given the focus of the webinar on health and safety, is really have Molly share her feedback on how we leverage schools for surveillance and contact tracing of families. But if we can get a quick answer on temperature checks, I think we can then transition into contact tracing and surveillance.
Exactly. That's where I was going as well. Thanks, Mary.
Okay, so real quickly on temperature checks. We don't have any data that they work in any setting, including in healthcare settings. I think that the logistics exceed what is reasonable in almost all conventionally resourced schools, and I think there are much better efforts placed on trying to detect children and staff who are ill. And with that, Molly.
What are we going to do, Molly? How are we going to enforce this policy? Yeah.
Oh, goodness. So we have been working very closely with the MSBA and encouraging our districts to work with their local health departments on what does contact tracing look like, and utilizing your nurses and utilizing, if I know some of our smaller school districts don't have this luxury, but if they have social workers, if they have case managers to help, and also their local federally qualified health centers and their local health providers can help with that contact tracing aspect. So we have some school districts that have the ability to have staff to go to the home. So they can go in, or they can do virtual screenings to see who has been exposed, and then how do we communicate that to our local health departments. And so some school districts, like I said, don't have that luxury. The nurses and the counselors have been the ones that are reporting it to their local health departments, or will have to be reporting it to the local health departments. And then how are they coordinating all of that information? But if you're reaching out to your community partners, whether that's your local mental health department, your health centers, and your hospital agencies, they can potentially help bridge some of those gaps with doing some of that community tracing for you, as well as the health department, to be able to manage some of that. Because like I said, our school nurses are going to be so overwhelmed. And if I have any advice to give you for any districts that are out there, I hope and I pray that you are having your school nurses at these tables really early and having these conversations with them to talk about their capacity to figure out, okay, and the reality is our school nurses know a lot of people in the community because they're referring to the health departments. They're referring to the local community health centers. So they might have individuals that say, hey, we can have this family reach out to this, or this family is already connected with this health agency, so they already have that relationship, and they can help do some of that screening and do some of those local, help with some of the contact tracing as well. And so I think there's a role that school-based health can play, and then there's a role that the community can play to help navigate that with your local health departments.
I think that's really important. I mean, I'm going to slow down there just to kind of absorb everything you just said, Molly. I mean, I think there's a couple of elements here, which is this partnership of the schools with the health departments and with the community, right? And what I see there is that the number one response is not that we're going to test every kid all the time. It's that we're going to do good symptom surveillance at the school level, which is, are you basic, it's sort of doing basic stuff. Are you sick? Is anyone sick in your house? And to be able to use that information to have a more flexible sick policy that's really well enforced. But to the degree in terms of determination for testing, or for contact tracing, that's where it's like that may be exceeding the capability of school districts, and that's where you need your health departments to really have that strong level of communication and partnership. Is that what I'm hearing from you, Molly? Right?
That's exactly what you're hearing from me. And I mean, Dr. Coffin, she's the expert. But I agree with her 100% that testing and temperature checks are not realistic in 99.9% of our schools, and they're not, I mean, I'm not a medical professional, but they're obviously not accurate. But we have some school districts that have reached out to us and says, we want our school nurses to take everyone's temperature at the door. And we are advising strongly against that utilize your school nurse. I mean, we will have schools, and I can see some of the questions maybe popping up, that our school nurse is also thinking, and when you think about Dr. Height, when Dr. Height talked about the space, so looking at your nursing office, what is the capacity? So when you talk about referring down a kid, because we're going to have a lot of potentially sick, especially in elementary school, sick kids that have a temperature, and we're just going to automatically assume, oh my gosh, they have COVID-19. So we're going to send these influx of kids to the nurses. Well, sometimes there's not a seamless process of how we're sending kids to the nurse's office, and that's something that we need to consider is what is that flow of traffic going to look like? And just because a kid has a temperature or just because a kid might be throwing up, do we need to send them to the nurse, and how are we doing that, and how are we monitoring that space? Be able to ensure that potentially non-sick kids that are coming down for like medication administration and all of these other things that nurses do, or how can we manage that flow to make sure that we're not potentially exposing other kids to someone who might have COVID-19 but might not. They might just have a fever because they're 5. So
Makes sense. Mayor, follow-up questions? Someone else wanted to say? Matt, did you want to say something?
No, I'm sorry, Dr. Rubin. I just want to apologize to the whole group. I urge you to continue the conversation. I unfortunately have a 3 o'clock waiting for me, but I thank you and Dr. Coffin, Dr. Heitbill, always good seeing you, and everyone. Thanks for the opportunity to be here. And again, at the department, we look forward to supporting everyone and working with networks in all of our communities to navigate these uncharted waters together and build confidence in our communities that we're going to care for them well. So thanks for the opportunity to be here, and my apologies that I have to slip away.
All right, thanks, Matt. I only got a couple more questions for the rest of you guys, just to kind of keep it moving. But, and, you know, to me, the other question, Susan, that Dr. Coffin, that I've heard you speak about is this issue of ventilation and physical structure. I mean, certainly we can use gymnasiums, we can use our outdoor environments early in the school year, try to space. Some people have proposed even using community buildings, and I think about that from a safety risk for kids and how you're going to, you know, whether you're going to use local churches or community centers for additional spacing. How much, but there are certainly areas we can't open the windows, right? And so how do you think about the issue of ventilation, you know, in relationship to these other strategies?
I guess I'd put it in the exact same bucket. If it's available to you, think about how you're going to use it. You know, in a, cold winter, you're not going to use your ventilation, even if you could throw open all of your windows. And so I think very few school districts will be able to rely on that as a primary intervention, but perhaps it could be part of a series of interventions if you have windows that open wide and can create some cross current. That's going to probably reduce the amount of settling that the respiratory droplets do that are being expelled and the amount of contamination that's in your environment. But I'm not sure, except in very close, small, packed spaces, that ventilation is a major driver of transmission or a major modifiable driver of transmission.
Very happy to hear that, Dr. Height, right?
Indeed.
But, the last question is I think about our families. I think about our grandparents and I think about, our caregivers, many of whom have their own chronic health conditions, and our teachers and our staff in the schools. What's your communication, particularly the families? These kids will be mixing. I sort of accept that despite our best efforts, kids will be kids. And how do we guide parents and caregivers and staff about what they can do to protect themselves as kids continue to go through to school through the fall? Have you guys thought about communications with parents and what that should look like? We can start with Susan, and then I'll go to Dr. Height and Molly,
Well, I'll just say that wearing my public health hat, this is a wonderful place for public health to partner with the school district and create good, strong messages that sound and work in concert with each other, so that what the child is learning at school about how to keep safe in school is mirroring what the family is learning at home, and operates in a somewhat recognizable way, with the guidance being given on how to behave in the community as we reopen different recreational and shopping opportunities. And so I think the more we can do to create a simple rubric that is recognizable across a whole bunch of different platforms, the better off we'll be in teaching all of us how to adapt our way of living and get ourselves closer to the key activities we want to pursue, like educating our kids and allowing them and ourselves to return to a more normal life.
Yeah, and I would agree with Dr. Coffin. And I mean, I think that we've seen this with nutrition and other things that we have started in schools that then communicate outward to families, where children are also helping to communicate a message that then becomes more broad-based throughout the community. I think that one of the things, though, Dr. Rubin, is we also have to be communicating while we're coming up with these plans, and be informed of the things that are on the minds of families and grandparents and caregivers, so that we are ensuring that we can be responsive to many of the questions or concerns that they may have moving forward. And one thing that we haven't talked about on this during this whole webinar are so we hear a lot of people saying, you know, until a vaccination is in place, I'm not going to send my child back, or I may not return. And I'd love to hear Dr. Coffin's response to, I mean, some of those comments that we're starting to hear more frequently now about about vaccinations and how we should be thinking about those now.
I think we all hope for an effective vaccine to come our way soon. I think we have to plan and prepare that it may not, and either it may take a long time for it to come, or it may not have as big an impact as a preventative as we would hope. And so I think we need to begin to think, how do we live in a truly diverse society where our elderly and our vulnerable and our disadvantaged reap the same types of benefits of participating and of protection. And I think that's where the complexity of schools comes in, because schools are one of those places where we meet across all of those differences. And I think that in that way, children help us create more equity in the way we protect the rest of the community. I don't know exactly what that looks like, but I do think that schools are really essential in providing protection across the communities.
Molly, what do you think?
I'll just kind of shadow what my colleagues are saying. Having consistent communication across the partners and across the public world is super important. And I really appreciate what Dr. Haidt said about, if you are having task force, if you are working together, bring that parent or guardian voice to the table. So have them potentially sit in as you're planning, as you're talking about reentry, and as you're coming up with some of these plans. Having that student and family voice, that's one thing at the School-Based Health Alliance that we speak to a lot, is how are you engaging that voice to say, hey, what do you all think about this? And just just to make sure that they feel like they are part of this community, since they are the ones that are utilizing the service. So I appreciate that as well. And then I think just constant communication through this whole process is going to potentially help ease anxiety, and potentially, as if we don't have a vaccine, if we're communicating what we're trying to do to keep everybody safe, I think that's going to relieve some of the anxiety with the staff and the students and the family. But having set protocols and talking with your school board and talking with your your overall departments, about your education department at the state level, about what are some of the policies that we can put in place for our staff if they choose to not come to work, if our families choose not to send their kids. So start thinking about that policy so the school board can help you, make some of those decisions and what that might look like.
Well, in my closing here, I think this is a good place to stop. I think, a couple things. I think that the more and more I've participated in conversations where things have gotten very nuanced and very specific, and you start to kind of realize we need more flexibility. It sort of reminds me that not all interventions are created equal, that the very simple things are often the easiest to do and also the most beneficial. The idea of the kid getting off the school bus and having a plan at home to wash hands when the kid comes in, or to shower up, to wipe down the books, to do good hygiene and disinfection in the schools, to really honor good sick policies this year. You get a lot of value from just those interventions before we even move on to masking and the distancing recommendations. And I know when I go to work, and we obviously work in a healthcare environment where we're seeing kids who are sick, that I feel when I'm armed with my mask, right, or I'm doing good hand hygiene, I feel safe. And I sort of would remind everyone out there that sometimes simple makes a lot of sense, right, and can be reassuring. And I think we've seen that already in this epidemic. And finally, I will disclose a little personal information. I am the son of a school teacher, and who spent her entire life working in the New York City public schools, PS 51 in New York City, in the Hell's Kitchen section of New York City. And I can tell you my admiration for what you guys do is significant. Your value, not just to the kids, but to our communities, is really important. So I'm looking forward that us at CHOP, to all of you out there who are educators or parents, we can support you as we get your kids back to school where they belong. All right. So thank you very much, everyone. And we look forward to continuing these webinars in the future. Good luck. All right.